Okay, the last 2 hours of the day. Oh, no, wait, I thought you wanted the 2-hour version, right? Tomatoes are being thrown up here. So this is a combination talk. It's a talk about some of the things about pseudotumor cerebri syndrome that you may not think about routinely. So it's to give you a little bit of a flavor for that. And a sort of basic primer about labor. This is to introduce you to some of the things that are going on with labor as well. So I'll start with the IIH topic. Here's a typical case. 28-year-old woman, 6-week history of headaches, transient visual obscurations. She's obese, she has 20/20 vision, normal eye movements, normal pupils. The fundus looks like this, bilateral papilledema, and the visual fields look like this, blind spot enlargement, but no other loss of vision in this particular case. So what do you do for that case? What's our teaching for IIH? I'm going to talk a little bit around that term later, but for now we'll call it IIH. What do? You make sure there's not a tumor there, number one. You make sure there's not hydrocephalus. You make sure there's not a structural abnormality that might be causing papilledema. You confirm that the intracranial pressure is high, so you've got to measure that with the lumbar puncture. You make sure that the CSF has normal composition. Make sure it's not meningitis, there aren't cells there, or blood, or something else. And you make sure there's no other neurologic deficit, except 6 cranial nerve palsies, which happen with elevated intracranial pressure. And then you treat them.
Don't you have to rule out sinus thrombosis?
Thank you. Have I ever worked with you before? Thank you for bringing that question up. I'm getting there. I'm getting to that. You wanted to be sure that I hit that question. I'm going to hit that. So here is things you might not know about IIH. Number one is we're moving away from calling it IIH. There's a sort of different terminology that I want to introduce to you and reinforce what many people are talking about with this. Second is that cerebral venous abnormalities are common. So someday we may not be calling this idiopathic. We may be calling it cerebral venous disease. The third is that the diagnosis might not require papilledema. I'm going to show you that briefly. The fourth is that sometimes this is an emergency. The case I showed you, not an emergency, but sometimes it is. And 5 is that there are some people now, including I learned last week, Neil Miller at Hopkins, who are starting to propose that cerebral venous stenting for IIH, for the ones that need surgery, may be the first thing you do surgically. It's not there yet, but it's something to think about. So, what are the diagnostic criteria for this? So this is back in 2002, Dr. Friedman got this written up as sort of the standard way that you make the diagnosis of IIH. High intracranial pressure, over 250 millimeters of water, normal composition CSF, no other specific cause. And as I mentioned earlier, these are the specific causes that you might think about that produce the problem. So you make sure those aren't there. In 2013, she and another group started to sort of reclassify this and talk about the pseudotumor cerebri syndrome. So this disorder has gone from being pseudotumor cerebri to benign intracranial hypertension to idiopathic intracranial hypertension, and now it's coming back full circle to calling it pseudotumor cerebri, but pseudotumor cerebri syndrome. So a lot of the experts are looking at it this way now, and the primary pseudotumor cerebri syndrome is what you would think of as IIH. That's the 90% obese patients with no other known cause, although we're going to look at that cerebral venous issue. And then there are a bunch of secondary causes, endocrine imbalance, certain medications, and the cerebral venous disease. So think about naming it according to that. The cerebral venous disease is an important issue, and I'm going to go back and forth talking about this as we go through the lecture. So cerebral venous disease, you need an MR venogram to diagnose this. You may get some of the information on an MRI, but for the most part, you need an MR venogram to do this. So if you have a patient you suspect of pseudotumor cerebri syndrome, you need an MR venogram as well as something to rule out a mass. So you're looking for venous sinus thrombosis, which in this MR venogram has absence of the superior sagittal sinus where it ought to be here. Venous sinus stenosis, which is, if you look at the transverse sinus coming down this side, there's an area here that's very narrowed. And occasionally you'll see venous sinus AV fistulas, malformations, which often you can't diagnose unless you do an angiogram. You can see this little blush of vessels in this region. But this is just equivalent to the durocavernous fistulas you see around the cavernous sinus, abnormal flow. And in this case, it raises the intracranial pressure. So thrombosis is the big worry when you see somebody with IIH. It's elevated intracranial pressure. It's due to decreased CSF resorption. And the infection cases, you're not going to mistake those for IIH, but there are a significant number of them that are chronic aseptic cases, and they can masquerade as IIH. So the management is totally different. You need to find out whether somebody's got a venous sinus thrombosis, and if you find it, they need a vasculitis workup, they need a hypercoagulability workup, they need anticoagulation if you're seeing this in the early phases to prevent stroke. If you're seeing them a lot later, you probably won't anticoagulate them, but you'll get the neurologist or the insurance involved with that to make that decision. But in the acute phase, there's a risk of stroke, and so you got to look at that. And you do things to lower the intracranial pressure. So an important diagnosis to make. This stenosis issue is what's come up in recent years, and depending on what kind of MR venogram you're doing, if you do this so-called ATECO, which is, I've got it written down here because I can never remember it, it's auto-triggered elliptic centric ordered MR venogram. But it gives you these very high resolution 3D pictures. And if you do those, you're probably going to see venous stenosis in more than 90% of the primary pseudotumor cerebri syndrome or IIH patients. So it's very common. And the question is whether that stenosis is causing the elevated intracranial pressure or whether it's the result of increased intracranial pressure. So if there's a stenotic area there, it's blocking the flow in the veins. That backup causes increased pressure in the brain. Or the brain swelling from whatever other cause IIH is there, squeezes on the vein and closes it. The people who talk about stenting this say that it doesn't really matter which comes first. If you open the vein up, it breaks that cycle, whether it's the start or the end, and you reduce the pressure. So we'll look at that a little bit later as well. So you're looking for venous stenosis as well. If you look carefully like this, you're going to see it commonly in IIH patients. And finally, this fistula issue. We've seen a few of these, and it's in cases that have IIH. We look at the venous stenosis. We sometimes stent the stenosis, still doesn't get better. And then we look more carefully on catheter angiography, and you see that there's an abnormal blush there. Sometimes the stenosis results in this. And these both can go either way. You can have the fistula developing stenosis. You can have stenosis developing fistula. This is a rare cause of refractory IIH. Doesn't respond to anything. Not usually going to see that. So you can have pseudotumor cerebri syndrome without papilledema. So in order to make that definite diagnosis, you need to have a high pressure, normal CSF, no other specific cause. So you've done an MRI and you've made sure about that, and you've got a 6th nerve palsy, but you don't have papilledema. So you can, with the right syndrome, you can make the definite diagnosis. You can have a suggested diagnosis of pseudotumor cerebri syndrome without papilledema if you have these features again, and you have 3 of 4 of these additional features on imaging. Empty cella, globe flattening, distended space, venous stenosis, like this. So if you have those first 3 things that I told you about, and you have 3 out of 4 of these, anticella, flattened globe back here posteriorly, widened CSF space, venous stenosis on that. You can call that pseudotumor cerebri syndrome. Okay, forget I said that. Don't ever diagnose pseudotumor cerebri syndrome without papilledema. This is a specialist diagnosis, but you can have that happen. This is what I tell our residents. Do not get yourself in trouble by making this diagnosis. All right, so IIH, the 3 degrees of primary pseudotumor cerebri syndrome, or IIH. The not too bad, the pretty bad, and the really bad. So let's go through what those look like. This is the not too bad case. 32-year-old woman, this is what I showed you earlier. Mild papilledema, some symptoms but not severe, the classic obese patient. Everything else is normal, and the fields show an enlarged blind spot, but that's it. The MRI shows no tumor. The MR venogram shows no thrombosis. The lumbar puncture shows an opening pressure that's mildly elevated. So it's over 250, but it's not 500. And the composition of the CSF is normal. So I would say this is the kind of not too bad, most common pseudotumor cerebri syndrome case that you're going to see. And your options are, you can do nothing. In these cases that have mild symptoms, if you're able to follow them, you can treat their headaches and watch them. If they're obese, obviously encourage them to lose weight. You don't have to lose 100 pounds to make a difference in these cases. I mean, sometimes these patients are 200, 300, 400 pounds in weight. They don't have to lose 100 pounds. They need to lose 5 to 15% of the body weight, and they can potentially reverse the syndrome. So that's what I tell them, to encourage them to get into a weight loss program, is that it's not an insurmountable task. You can treat them with Diamox, acetazolamide. What we've learned from the IIH-TT, was our recent clinical trial looking at whether Diamox was effective in mild cases of IIH, that you can use up to 4 grams a day, interestingly. We used to think a gram was a lot, 2 grams was really a lot, and you could never go farther than that. This trial showed us that patients eventually tolerate 4 grams a day reasonably well, and they don't develop complications for the most part. So none, weight loss, Diamox, that's usually all you need. If they're not responsive, you can consider others. Some people believe in the use of furosemide if acetazolamide is not tolerated. Topiramate, Topamax, that's the treatment. And usually they do well. They usually don't need surgery. You follow them for a while, the disc edema goes away, and you monitor them basically. Here's the pretty bad case. So, 28-year-old obese woman on 3 grams a day of acetazolamide already. She has transient visual obscurations that are getting worse. Visual acuity is good in one eye, starting to drop in the left eye a little bit. And the papilledema and the visual fields are worsening. So it's a case that has significant papilledema, but the field started here, going to here now. So this is more of a worrisome scenario. And here are your options. This is going to be a surgical case for the most part. If you're on maximum medical therapy, you got to think about what surgery you might do. Optic nerve sheath decompression, relatively effective for this disorder. Some sort of CSF diversion, lumbar peritoneal shunt, ventricular peritoneal shunt, some sort of shunt with this. And as I mentioned earlier, there are those who believe that it may be the time to think about doing cerebral venous stenting as a first-line therapy if they need surgery. We'll get back to that. And here's the case that you might not know about. So I wanted to sort of make everybody aware of this. There is a subcategory of pseudotumor cerebri syndrome, the so-called fulminant IIH, which is much different than what I just told you. So, 28-year-old obese woman again, worsening headache, worsening transient visual obscurations. 5 days ago, she saw her optometrist and she was 20/30 in both eyes. In the past 5 days, vision has become dark in both eyes, and she's 20/70 in one eye, counting fingers only in the left eye. There's a relative afferent pupillary defect in the left eye. And those are her discs, and those are her fields. So this one is starting to develop some peripheral loss. The left eye has severe generalized contraction with some central sparing in that area. So that would classify it as fulminant IIH. And the way that it's defined is that it's acute. So less than 4 weeks from the onset of documented elevated intracranial pressure symptoms and severe visual loss, and a rapid worsening of visual loss over a few days. And it's estimated in the 2 to 3% of overall IIH patients. So not common, but you need to know what to do if you see this patient. This is completely different. So your differential diagnosis is different. They got visual loss and they got severe edema. So you got to think about whether this is papilledema from usual causes, but you also have to think about, is this malignant hypertension? You got to make sure about their blood pressure. You got to make sure they don't have some atypical form of optic nerve inflammatory disease or infiltrated disease. Anything that's got severe visual loss like that, the differential diagnosis widens, and you've got to sort of look into whether it's something like this. So what do? This patient gets admitted. This is not go home, take some Diamox, and see you in 2 weeks. This is admit, because these are the patients that end up like this no light perception eye from a pseudotumor cerebri case.
How many days can it take to know that?
How many days does it take?
It may take till that time.
To get like this would take a while, but you don't need to look like that to be no light perception. They can go to no light perception in a few days. Yes, it's very fast, and that's the reason you have to be jumping on this. So they are admitted. They get urgent neuroimaging, MRI, and MR venogram as well. They get the lumbar puncture to document what's going on. What if you got a pressure that's 500? You know, we were talking about the first one, it was 250 to 300. What if it's 500? Normal cells, protein and glucose are normal, but the pressure is sky high in this case. You can give them Diamox, however much you can give them. In these cases of acute visual loss related to these, there's some evidence from Dr. Liu at University of Pennsylvania that a short course of high-dose intravenous methylprednisolone, usually leading up to surgery, but a couple of days at least, of a gram of methylprednisolone a day, improves the visual outcome in these cases. So typically, if this patient is admitted, we'll give them a bolus of intravenous steroids. We don't usually do that for IIH, but for this scenario, we do. And then you consider the use of a lumbar drain. So here's the evidence from Dr. Liu. This is a paper now, 20, how many years? 1994, looking at fulminant IIH and treated with a gram of methylprednisolone a day for 5 days and then tapered. And 3 of those 4 patients did not need surgery, even though they were in this horrendous category. So this is kind of the basis for what we do, giving a short bolus of IV steroids. When the pressure is 600, you got to do something right away. So the insertion of a lumbar drain allows you for immediate control of the lowering of the pressure and controlling the pressure. It allows you time for the patient to respond to medication, that's steroids, for example, and to prepare them for surgical intervention and get them stabilized. In some cases, they put the drain in and you can monitor them and eventually wean them off the drain. They might not need surgery. But most of these patients are going to need surgery. So the drain helps you control them and prevent them from having other bad complications while you're getting ready to do that. So again, if there's improvement, you can occasionally get them off of the drain, have the steroids and watch them. But if not, we'll usually watch these patients for a few days, and if they're not responding, they're going to get surgery. And first line, often if there's a lot of vision loss like this, the first line would be an optic nerve sheath decompression in that affected eye to protect the vision primarily. Eventually, a lot of them are going to need a CSF diversion procedure after, so they're going to get both in this scenario. And then we monitor for effect after that. There's a little bit of data, not much because it's not a common situation. The largest series that I've seen in this is 16 cases. All of them had acute loss, were obese. The mean opening pressure, 550 almost. They all got steroids. They all were treated surgically with one of them. Half of them were legally blind after the treatment. All of them had field loss and optic atrophy after, as opposed to your usual pseudotumor cerebri case. Yes?
Why do you do optic nerve sheath fenestration if they're going to get a VP shunt anyway?
For just to get done faster. It depends on your institution. If you have somebody there who can do a sheath fenestration, you can do it under local. You can get this done to protect that one eye that's going bad. The shunt is a more definitive treatment for lowering the pressure over the long term. but it's a protective, fast protective measure. That will not be the case in every institution. Some may not have anybody who can do sheath decompression. Okay, so this is managed differently. Admit, urgent diagnostic test, aggressive steps to lower the pressure, consider a drain, and the prognosis is guarded there. So let's talk a little bit more about this venous sinus stenosis thing and the use of a stent as a first-line therapy. So I showed you this slide already. Here's the woman again, getting worse, surgical candidate for pseudotumor cerebri syndrome. And in this case, you've done this MR venogram and found that there's a venous stenosis here, which, as I said, depending on how good your imaging is, you're going to find some degree of that in maybe 90% of patients with primary IIH. So here's what you got to do if you're considering stenting. You have to do an MRV to identify the stenosis. You got to, if it's the dominant vein or if there's bilateral stenosis, you can proceed. If it's not the dominant vein or if it's unilateral in the non-dominant vein, you're not going to get a benefit from this. So you're really looking for stenosis in the dominant vein or bilateral stenosis. Some people believe that you can take some CSF off, so do a lumbar puncture, remove the fluid, and see if that stenosis resolves. So see if that patient is one of those that has brain swelling, it's compressing the vein, causing the stenosis. And if you do something to reduce the brain swelling by lowering the pressure with a lumbar puncture, and they get better, then you don't stent. You have to do a direct retrograde catheter, venography and manometry to see what the gradient is across that stenosis. Because stenosis is common, significant stenosis is not as common. And if it's not significant, you're not going to get a benefit from the stent. So you've done an MRV, you've maybe done a lumbar puncture to take off fluid. Now you've done a retrograde catheter to measure the gradient, and if you get the right measurements across that and you think it's significant, you go forward. Then, what do you have to do to put a stent in? Okay, you've had the venography. To do a stent, you need double antiplatelet therapy for a week prior to the procedure. They're going to be under general anesthesia. They're going to be heparinized in addition to the antiplatelet therapy. You've got to do retrograde femoral catheterization and placement. And depending on what group you're talking about, they've got to be on antiplatelet therapy after minimum of 6 months. In general, most people who do this say 6 months, maybe up to a year. So you're putting the stent in, again, to open up that stenotic region, breaking the cycle somehow and lowering the pressure. Well, it's a lot of stuff, but there's an argument for doing it. This is from Halmaji's group, which is from Sydney in Australia. This was their original big paper back from 2011. 52 patients with refractory IIH and stenosis. They had the stent put in. All of them eliminated the stenosis, the gradient across the stenosis, the papilledema, and the symptoms. And that was with a follow-up of 2 years. They are big proponents of this, and it's still a controversial procedure. But the results they have reported are pretty dramatic for effectively treating this. It's got some risks involved, you'll see. So about 10% of them had restenosis. So next to that stenotic area, next to the stented area, things close up again. They need a repeat procedure. But usually one procedure is all that's needed in those cases, at least for the follow-up that we have so far. So most of those have been successfully treated with a re-stent. There are a couple of hemorrhages associated with it. So this is an intracranial hemorrhage. That's not going to happen from optic nerve sheath decompression. It's going to very rarely happen from shunting. So this is a bad thing that can happen from this. There was one death from acute elevated intracranial pressure, but it was felt not to be due to the stent in this series, due to anesthesia, not the stenting. But again, it's somebody who had to have general anesthesia for this. Diversion complications, less, of course, but there are still significant problems with any of these treatments. So if you do a shunt of some sort, about 1% mortality, failing in over half of them within 6 months. So if you do a shunt on somebody, the likelihood is you're going to have to do another shunt. They move, they get obstructed, they get infected. So you're committing them to a long-term problem with this. Sheath fenestration, the complication rates are generally minor, but the one complication rate that can happen with sheath fenestration that usually doesn't with these is you can get a central retinal artery occlusion from spasm when you're back there manipulating to do the procedure. And they fail quite frequently. So none of these are perfect treatments. There have been some trials now, aside from the Homogy trial. This is from New York, small series, 13 patients. Again, all of these are refractory IIH patients with a stenosis and a significant gradient across the stenosis, pre, post, clearly remedies the stenotic part of the vein. And their 3-month data analysis were 21 out of the 26 improved their field, 20 out of the 24 improved their papilledema. All of them had lowered cranial pressure. So it works to do it. It's just a matter of whether it's worth the risks, basically. And then this small series, again, some restenosis, one retroperitoneal hemorrhage that did not have late complications and so forth. So there are some of these complications that are there in place for this. So it's something that we're looking into over time. In the patients that have severe stenosis, very large gradients, and are not responsive to the other treatments, many groups are starting to think about this as a primary therapy. It's not done very often, but it's a consideration. Okay, so things you might not know about IIH. Again, we're moving away from calling it IIH. Cerebral venous abnormalities are common. May not require papilledema, but don't ever make that diagnosis. Sometimes it's an emergency, and there are proponents for cerebral venous stenting. So any questions about IIH? The last part is labor, and it's fairly short.
Visual field depends where per month, or it depends how fast you can.
It depends how fast. If you, like that, the patients that have blind spot enlargement usually will recover completely once the papilledema goes away. The ones that have more sort of progressive impairment, it depends how fast you treat them. They are potentially recoverable.
But do you know, or you can say how long do you need, and what is the time that after it's not possible to get it back?
There's not a hard and fast answer for that. It depends on a lot of factors, how long it's been there, how high the pressure is, how bad the papilledema is there now. It's hard to predict that.